Hello, everyone. On behalf of the American Urological Association, it is my pleasure to welcome you to the 2021 AUA annual meeting and the inaugural Maghreb Federation of Urology program. This program is an important collaboration between the AUA and the Maghreb Federation. I look forward to continuing to build a strong foundation of friendship and collaboration with the urologic community in this region. While we would prefer to be together in person, I'm pleased to be participating and happy that the program can be held virtually. The exchange of knowledge is critical to the continued success of urology around the world now more than ever. It has been inspiring to see how the global urologic community has responded to the immense challenges before us. It is your dedication and commitment to provide the highest quality of care to our patients that has continued to shine throughout this uncertainty. I would like to thank Dr. Mustafa Al-Cherqui for his efforts to establish this program, as well as Dr. Harouni and Zeribi and all of the speakers and moderators for their efforts to organize this excellent session. I hope that you enjoy the program and look forward to seeing all of you again in person very soon, and hopefully at the Moroccan Urological Association Congress in Tangier this October. Thank you very much.
The Algerian Association of Urology and Algerian urological surgeons are honored to be able to participate in the annual meeting of the American Association of Urology. Through the Maghrebian session, this is the first time, and we hope that it will become a tradition with an active participation and face-to-face. During this session, we will discuss 3 common pathologies and especially their management in our Maghrebian context. We have been attending the American Association of Urology meeting for more than 12 years, but having a Maghrebian session with an exchange of experience and expertise can be beneficial and ultimately develop a solid partnership between our scientific societies. We would like to thank the American Association of Urology for having allowed this participation and for having accepted to organize this first Maghrebian session within its annual Congress. Thank you, Mohamed Harouni, Chairman of the Algerian Association of Urology.
Dear colleagues, I am Dr. Ahmed Said Zeribi, Vice President of the Tunisian Association of Urology. I'm delighted to have the opportunity to speak to you today on behalf of the Tunisian Association of Urology and to express our deep gratitude to the American Urological Association for this kind invitation for the first time and the prestigious and greatest urological meeting in the world. Tunisia is a country on the Mediterranean Sea coast. It has the northernmost tip in Africa, and it is in 1-hour flight from Europe. In Tunisia, we are 400 urologists for a population of 12 million. We work either in 100 private clinics or in more than 25 public or academic hospitals. With our neighbors in Maghreb countries, we have more similitudes than difference in history, culture, and also medicine and diseases profile. We have been collaborating for years to develop a modern and up-to-date medicine. We are focusing in the last years on early detection and prevention of diseases and developing a data set and planning for observational studies. Our needs are to create an extensive community of participants who contribute with their diverse skills, views, and expertise to the future of urology. Our hope is to develop privileged relationship and fruitful collaboration with American Urological Association, and why not to initiate exchange programs in the future. I seize this opportunity and I have a great honor and pleasure to invite you to the upcoming Pan-African Urological Surgeon Association Congress that Tunisia has the privilege to host in October 2022. Thank you.
Dear ladies and gentlemen, on behalf of the Maghrébine Federation of Urology and the President of the Maghreb Urology Association, I would like to thank the American Association of Urology and its Secretary, Dr. Dunstead, for accepting to introduce Maghreb session in its program. This is the first time we have the privilege to participate in this event. We are honored by your trust and hope that our collaboration will continue in the future. The Moroccan Urology Association has already carried out 2 webinars with the American Urology Association. Our goal is to establish working program with the Maghrebian Federation. We wish to perpetuate this event to become a permanent part of the AUA Congress. We have selected topics which are common and which have Maghrebian peculiarities. Before starting this session, I give the word to Dr. Harouni, President of the Algerian Association, and Dr. Zribi on behalf of the Tunisian Association. After that, we will start our session with the first topic, bladder tumors.
It's my great pleasure to be among you today and participate with this summary presentation entitled Particularity of Non-Muscle Invasive Bladder Cancer in Moroccan Population. Bladder cancer is diagnosed or treated in more than 2.5 million people worldwide each year. It's the most commonly diagnosed cancer in the male population worldwide, while it drops to the 10th rank when both genders are considered. It's responsible for 3% of all deaths caused by cancer. It's the second most common urological cancer after prostate cancer. The majority of cases occur after the age of 60. Tobacco smoking is the most important risk factor for bladder cancer, accounting for approximately 50% of cases, followed by chemical exposure, chronic bladder irritation, and prior pelvic irradiation. At diagnosis, 75 to 85% of cases are non-muscle invasive bladder tumors. Natural history of non-muscle invasive bladder cancer is characterized by the occurrence of recurrence and progression. Several adverse prognostic features have been associated with a high risk of recurrence and progression. Based on these prognostic factors, risk classification models are expected to improve the predictive accuracy of identifying high-risk patients. Among these models for prediction of the risk of NMIBC recurrence and progression, 2 risk models are widely known: European Organization for Research and Treatment of Cancer Risk Tables and the Spanish Urological Club for Oncological Treatment Scoring Model. According to the Cancer Registry of the Grand Casablanca region, bladder cancer represents 3.1% of all the new cancer cases. 85.3% were males with a sex ratio of 5.7. In our context, bladder cancer is one of the most expensive diseases to treat. The majority of patients are over 70 years of age. According to the results of a recent study carried out in our urology department and based on the analysis of data of 300 patients with non-muscle invasive bladder cancer, urothelial carcinoma is the most common histologic subtype. Smoking history was found in 81% of patients. 91% of patients complained of gross hematuria as presenting symptom, and urothelial carcinoma of upper urinary tract was diagnosed during follow-up in 80% of cases. Multifocal tumors were seen in 44% of patients. Tumor size was greater than or equal to 3 cm in 48% of cases. T-stage was as follows: 58% were TA and 42% were T1. Concomitant carcinoma in situ was found in 14.7% of cases, and high grade was found in 41% of patients. After a follow-up of 53 months, the recurrence rate was 52% and the progression rate was 2.33%. In conclusion, the risk factors of recurrence and progression of NMIBC in Moroccan population are consistent with the current literature. Recurrence rate is high in comparison with other studies, but progression rate to muscle-invasive bladder cancer is relatively low. Further multicentric studies are needed to evaluate all risk factors and develop a model adapted to our patients. And the integration of molecular markers is also a promising approach.
Hello everyone, I would like to thank the American Association of Urology and the Algerian Association of Urology for the opportunity to present the result of the study entitled Unblocked Resection of an MIBC less than 3 centimeters. Bladder cancer affects 2.7 million people worldwide per year, 7th most common cancer death, and the 2nd most common urological cancer. Its incidence increases with age. It joins breast and colon cancer after 75 years old. Smoking and occupational exposure are the most recognized risk factor. Hematuria is the most frequent revealing sign. Transurethral resection is the initial and reference treatment for an MIBC, and urothelial carcinoma is the most frequent histological type. Epidemiologically, it's the first most common cancer in men and the 17th in women. The highest incidence is found in Europe, the USA, and North Africa. The annual number of deaths estimated at 38,000 in the European Union and 170,000 in the United States of America. Globocon 2018 estimates the number of new cases of bladder tumors worldwide per year to be 549,083% of all other sites, and the number of deaths to be 199,000, i.e. a rate of 2%. The survival rate is incomparable to those of kidney and prostate cancer. The standardized incidence of bladder cancer in Algeria exceeds 10 cases per 100,000. In our department, bladder cancer is the first urological cancer, followed by prostate cancer. What's the problematic? An MIBC remains a public health problem related to recurrence and progression because conventional transurethral resection has limitations, which are resection by successive passage of the loop, progression step by step in depth to the bladder muscle, leading to search of error in the evaluation of the tumor stage, release of tumor cells, high rate of recurrence and tumor progression. All these things motivating us to adopt a new technique of endoscopic unblocked resection, which is done in healthy zone and not in full tumor. What are the objectives of our study? The main objective of our work is to evaluate the contribution of a non-block endoscopic resection in the treatment of an MIBC, its impact on the prevention of recurrence and progression in short and medium term. The current challenge is to popularize the in-block resection for superficial bladder cancer because it allows to take the tumor and the detrusor in one piece, to decrease the risk of release of tumor cells and to decrease the risk of recurrence and progression. The secondary objectives are to improve the quality of the reading and the pathological staging on an in-block endoscopic resection specimens of an MIBC and the generalization of the technique. The study was a descriptive and prospective observational study, about 101 patients over a period of 27 months from January 2018 to April 2020. The exploitation of the result was done on the SPSS 20 and the location of study Urological Surgery Department of the Military Regional University Hospital of Oran. Here are our inclusion criteria: age superior to 18 years old, tumor less than or equal to 3 centimeters, both sexes, low risk, intermediate risk, and high risk on MIBC. Here are our exclusion criteria: patients with a bladder graft on an upper urinary tract tumor, tumor located on the anterior wall, other pathological types than urothelial carcinomas, and MIBC very high risk, and MIBC on pathological results, and finally, a consenting patient. Concerning the equipment, it is the same equipment used for conventional endoscopic surgery for transurethral resection of the bladder. And how about the procedure of the intervention? The resection, we must delimit the resection area in a circular form, 5 mm distant to the tumor. The resection is then done from this area, taking the tumor and the lying detrusor step by step and in a retrograde way until the tumor is removed. Meticulous coagulation of the resection site. We see 3 videos: monopolar unblock resection, bipolar unblock resection, and laser unblock resection. Recovery of the tumor using the loop or basket dormia. Piece sent for pathological study. These are our results. The mean age was 65.57 years old with extremes from 28 to 84 years. The most affected age group is the group of 60-69 years old. We note a marked predominance with 98 men and 3 women, i.e. sex ratio of 32. The most frequently described mode of revelation was hematuria in 62 patients. The most risk factor was smoking, found in 69 patients. All patients had a preoperative urinary cytology. It was negative for 98 patients and positive for 3 patients. All patients benefited of an abdominopelvic ultrasound, which gave us information on the volume of bladder tumors. The average size was 19.80 millimeters, with extremes ranging from 11 to 29 millimeters. 96 bladder tumors were pedunculated and 5 were flat. Here are pictures showing pedunculated and flat bladder tumors. The supratrigonal situation was the most frequent in 38 patients. In our study, perioperative urinary cytology was positive for 3 patients and negative for 98 patients. We performed en bloc resection of bladder tumors with monopolar search for 51 patients, bipolar search for 48 patients, and other search for 2 patients. Here are photos of monopolar and bipolar resections, also an image of the bipolar energy search. Here is an image of an en-bloc laser resection and an image of the search and laser fiber. The mean operative time was 23.86 minutes, with extremes from 13 to 42 minutes. We observed obturator nerve reflex in 2 cases, which caused 2 extraperitoneal bladder perforations. We observed 2 postoperative complications, grade 1 of Clavian and Dendo and grade 3 of Clavian and Dendo, with postoperative bleeding requiring revision. The mean duration of postoperative bladder catheterization was 24.95 hours, with extremes from 24 to 120 hours. How about the duration of the hospitalization? It's the duration of postoperative hospitalization. In our study, the average duration of hospitalization was 24.48 hours, with extreme from 24 to 48 hours. Here is an image of an en-bloc resected and table summarizing our pathological results. Low-grade PTA in 30 patients, high-grade PTA in 10 patients, low-grade PT1 in 45 patients, and high-grade PT1 in 16 patients. This is an image of a pathological aspect of an en-bloc resected tumor. The red pointer shows the thickness of the bladder musk downstream of the chorion of the tumor. Here is the microscopic aspect of positive intraoperative urinary cytology, category 5 of the Paris classification. The mean distance tumor base resection base was 2.54 millimeters, with the extreme from 2 to 4 millimeters. In our study, patients were classified into risk groups. 30 patients were classified as low risk and 71 patients were classified as high risk. In our study, detrusor was present on all resection chips. Endovesical installation of mitomycin C and BCG were performed, started between the 4th and the 6th week after surgery if no contraindicated situation. How about recurrence? 5 recurrences were detected, no recurrence for the group low risk NMIBC, and 5 recurrences in the group high risk NMIBC at the 9, the 12, 18, and 21 months. All the recurrences were outside the first tumor site. How about progression? Progression was observed in 3 patients of the 5 who had recurred. 2 cases of progression from a high-grade PTA to a high-grade PT1, and 1 case of progression from a low-grade PT1 to a high-grade PT1. How about the recurrence-free survival? Recurrence-free survival was, we had 99% recurrence-free survival at 9 months, 97% at 12 months, 96% at 18 months, and 94% at 21, 24, and 27 months. This is recurrence-free survival curve in our study. and here is the recurrence-free survival curve according to pathological stage and grade. 61 patients with PT1 urothelial carcinoma underwent second loop resection after 5 weeks. All pathology results come back negative. As a conclusion, at the end of our work and after surgery of 401 patients with an MIBC less than 3 centimeters, we can conclude that unblocked resection of an MIBC less than 3 centimeters is a safe and effective technique. This technique is safe because of the low rate of per- and postoperative complication found in our study and in the different published studies in comparison with conventional endoscopic resection. This technique can be performed with different energy sources, which would enhance the prevention of perioperative complications such as bleeding, obturator nerve reflex, and transurethral reabsorption syndrome, and more especially when using the bipolar search and the laser search. Shorter operating bladder catheterization and hospitalization time, thus permitting an appreciated rotation coefficient at the department. It allows to have excellent tumor specimen in a single block with almost constant presence of the detrusor, making easier the pathological interpretation and consequently a better staging of the disease. This quality of resection and this ease of pathological interpretation will certainly allow to define later a notion of surgical margins beyond which a second resection for revariation will have no place. The efficacy of this technique is demonstrated by the low rate of recurrence and progression of tumors after a correctly performed procedure in opposition to conventional endoscopic resection. This is essentially due to the deepness of the resection and essentially to the respect of a major carcinological rule, which is the absence of liberation of tumor cells during the operation. All these results allows us to recommend this technique each time it's possible in the management of an MIBC of less than 3 centimeters. Thank you for your attention.
Dear Chairman and colleagues, Tunisia is a country of North Africa. Tunisia's accessible Mediterranean Sea coastline and strategic location have attracted conquerors and visitors throughout the ages. And its really access to the Sahara has brought its people into contact with the inhabitants of the African interior. Tunisia is the most beautiful country in the world. Life expectancy in Tunisia has increased sharply since 1956. Currently, it's 74 years for men and 78 years for women. Even if actually the Tunisian population is relatively young, the wave is going up with the aging population. Considering advanced age is the risk factor of bladder cancer, the incidence of the disease will certainly increase. The incidence of this cancer is high in North America, the Eastern Mediterranean, Southern and Western Europe, and some regions of North Africa. In all cases, the incidence of bladder cancer is 3-4 times higher in men than in women, and the incidence of this disease increases with aging. Worldwide, approximately 200,000 patients died from bladder cancer in 2018. The global age standardized incidence rates for mortality among male is 3.2 per 100,000 per year. In Tunisia, according to data from Globocan 2020, 1,406 new cases of bladder cancer was diagnosed and 822 deaths from this cancer. Bladder cancer is in the top 10 of cancers in Tunisia for incidence and mortality. Is the third male cancer, the 9th female cancer, and 5th cancer mortality. The data on bladder cancer in Tunisia are rare. There are few studies evaluating the prevalence and the risk factors of bladder cancer. Only hospital-based cancer registry information and the report of Tunisian Society of Surgery are available. We updated our guidelines to Tunisian reality since September 2013. Recently, in the Tunisian Association of Urology carried out a retrospective multi-center national epidemiologic study on bladder cancer for 5 years, from January 2015 to December 2019. We thank all the centers and investigators who participated in including 2,047 patients. Bladder cancer is diagnosed in men in 19.3% with a sex ratio of 9.3. More than a third of the patients are from Bladder Tumors, where the large public and private hospitals that recruit patients from northern Tunisia are located. The South is poorly represented in this study because the participation of the southern centers is low in this study. The average age of patients is 66 years, with extremes ranging from 16 to 100 years. Smoking is the most important risk factor observed in about 58% of patients. In 4.2 of the patients, we find the notion of exposure to the carcinogenic agents. For the circumstance of this recovery, hematuria is the most important symptom observed in 83% of cases, while symptoms related to bladder irritability are seen in 38% of cases. All patients underwent cystoscopy and endoscopic tumor resection. The average size of the tumor is 3.7 centimeters. The tumor is unique in 58% and multifocal in 42%. The appearance of the tumor is papillary in the majority of cases, over 3/4 of patients, and carcinoma in situ was observed in 5% of patients. According to the anatomopathologic study, the tumor infiltrated the bladder muscle in 24% of cases, and in 3/4 of cases is superficial. For the tumor grade is shared almost equally between the 3 grades, grade 1, 2, and 3. For non-muscle infiltration in bladder cancer, patients underwent BCG therapy in addition to transurethral resection of bladder tumor in more than half of the cases. We don't use amethicillin in Tunisia. For muscle infiltration of bladder cancer, cystectomy is associated with transileal ureterostomy in the majority of cases. Neoadjuvant chemotherapy is recently used, which explains its use in only 1.3 of patients. According to the World Health Organization, Tunisia has observed in highest level of tobacco consumption and among Arab and African countries. In 2017, Tunisia had nearly 2 million smokers, according to the Health Ministry, and 25% of young people start smoking by the age of 11. Health culture and awareness raising remain the main means of fighting smoking. For this year, Tunisia has chosen the slogan, "Smoking cessation give you a new chance to live," for World No Tobacco Day. The World Health Organization Framework Convention for Tobacco Control, ratified by Tunisia in 2010, remains the best response to the globalization of this scourge. This treaty concerns several fields of action: health warning, protection against exposure to smoke, the fight against the illicit trade in tobacco products, advocacy, taxation, and help with quitting. Tunisia can find in this treaty all the necessary measures to establish a real tobacco control strategy. Tunisia has started its third cancer control plan between 2015 and 2021. The overall objective of the strategy is to provide a comprehensive framework to better orient existing and future activity with a view to 1. Reduce the incidence and impact of cancer on the population, reduce inequality linked to the cancer, strengthen health promotion, ensure rapid diagnosis and guarantee access to quality care, reduce the obstacle to access to cancer care, ensure rigorous planning by making the best use of available resources and identify additional resources necessary, develop research in oncology, and finally strengthen cancer registry and implement a monitoring and evaluating system. In conclusion, bladder cancer in Tunisia has an increasing trend due to smoking, aging of the population, and adoption of the Western life, the still life. More effort must be done by a public authority regarding the prevention of particularly reducing tobacco consumption, developing minimally intensive follow-up programs for patients with non-muscle infiltration bladder cancer, making high-quality facility for diagnosis and management accessible, and finally, developing ways to accurately identify patients who will benefit from expensive therapy. Thank you very much.
Hello everyone, it's a pleasure to be with you from a distance given the current health circumstance. Today, I have been assigned to present this presentation entitled Bilateral Coralliform Lithiasis, Management and Therapeutic. It's a frequent problem in our context. This type of lithiasis is the prerogative of developing countries. Generally in Africa, and especially in Morocco, there is a little data on coralliform lithiasis because absence of lithiasis registers. In the Department of Urology at the Ibn Rushd Hospital of Casablanca, the prevalence of urinary lithiasis was estimated at 7.8%, predominantly male-sex ratio. Coralliform lithiasis was bilateral in 2.3% of cases. Surgical management is a challenge for the urologists because of the complexity of this type of lithiasis and its impact on renal function, which requires an ideal choice of treatment. First of all, I will start this presentation with a clinical case stated in our department. It's about 52 years old lady who was admitted for the management of bilateral renal lithiasis, never operated on, type 2 diabetic on oral antidiabetics, and followed for ischemic heart disease on cardioaspirin. In addition, the patient reported an episode of stone emission. The history of the disease started 1 year ago, with the onset of bilateral low back pain, more accentuated on the right side, complicated by acute obstructive renal failure. The clinical examination found a patient aperitic, PS0, with microscopic hematuria without nitrites or ketones on urine dipstick. Biologically, there was acute renal failure. Radiologically, the renal ultrasound showed moderate bilateral bilocalicial dilatation with hyperechoic images with posterior acoustic shadowing. The patient underwent urinary drainage by bilateral double-G stenting. On this slide, we can clearly see on the abdominopelvic CT scan without contrast injection showing bilateral coralliform stones. On the right side, 3/3 cm diameter with a density of 1200 Hounsfield unit. On the left side, 4/3 cm diameter with a density of 1000 Hounsfield unit. Bilateral open surgical cure of lithiasis with intercostal lumpectomy as the approach. The surgical technique was sinus pilototomy with placement of arterial stent. In the first stage, the right side was attacked, then after 2 months, the left side. Post-operative follow-up was simple, except for an infection on the surgical wound on the right side. The evolution was marked by clinical and biological improvement, by the improvement on the renal functions. Radiologically, there was complete cleaning, no residual fragment. The surgical management of bilateral complex stones is a strategic issue based on the choice between delayed or sequential two-stage treatment, one side and then the other later, or simultaneous one-stage treatment, both sides in the same procedure. The current surgical approach is multimodal and includes the following options: extracorporeal lithotripsy with or without ureteral stenting, percutaneous nephrolitotomy, combination both of them, and flexible ureteroscopy combined with percutaneous nephrolitotomy. And the other options, open surgery was represented by radial or bivalve nephrolitotomy or sinus pilototomy. For the European Association of Urology, the reference treatment is PCNL, which is indicated even for the most complex lithiasis. This treatment can be combined with extracorporeal lithotripsy or flexible ureteroscopy. Open surgery will be reserved for the rare cases where other methods have failed. For the American Urological Association, PCNL is the third choice for the treatment of coralliform stones. 4 wide studies comparing PCNL to open surgery for complex stones have shown comparable stone-free rates. PCNL is the preferred treatment modality as it offers lower morbidity evidenced by decreased intraoperative and postoperative complications, decreased length of hospital stay, early return to work, and much smaller surgical incision. For the French Urological Association, the recommended treatment for coralliform stones is PCNL. Carried out as monotherapy, its effectiveness can be increased by the use of flexible ureteroscopy, the use of multiple accesses, or the addition of an extracorporeal lithotripsy. Open surgery is practically abandoned. Numerous other retrospective studies have demonstrated that untreated patients harboring complex stones are at risk for deterioration of renal function, including loss of the involved kidney, end-stage renal disease, infections, complications, and significant morbidity and mortality. Active treatment should be offered to patients with these stones. Bilateral coralliform stones are associated with more complications than unilateral ones. Conventional surgery is of interest before PCNL in certain specific situations, especially bone and kidney malformations. However, the surgery may be limited by learning, increasingly difficult to acquire by the younger generation of urologists due to the rarity of its indications, without forgetting the inflammatory reaction that can further complicate the procedure. Before concluding, I would like to share with you the images of a patient who was operated on last month with bilateral coralliform lithiasis. We started with the left side with extraction of the lithiasis by lobotomy. A few residual fragments of inferior calyci are still remaining, which will be treated by flexible ureteroscopy. In conclusion, PCNL should be the recommended first-line treatment for coralliform stones. Other surgical and non-surgical treatment options can be considered as a multimodal therapy or separately in certain circumstances. Thank you.
Good morning, everybody. I'm Dr. Razi, a urologist from the Department of Urology of the Dr. Mohammed Naqash Hospital from Algeria. First of all, I will thank the American Association of Urology that allows the Maghreb countries and allows me to be an active participant to this huge and important meeting. We will talk about the endoscopic combined internal surgery. Mr. Jack Fresco, who's an American self-taught engineer, said that the intelligent use of science and technology are the tools with which to achieve a new direction. History of stone treatment started with Perez Castro in 1974, who used first laser arthroscopy. Then in 1985, Mr. Woodside used the first PCNL in the 80s. The idea of combining both treatments emerged, and in 1987, the Gattaca-modified supramalleolar position gives new way for the PCNL. In 1993, Mr. Michael Grasso used the first prone endoscopic combined treatment using a semirectal arthroscope with PCNL. In 2008, we used for the first time the acronym of ICRS by Mr. Scoponi and his team in Italy. There are some limitations of stone monotherapy, even for PCNL or IRS. For PCNL, sometimes we have some difficulty, some trouble to have an access to some targeted calyx. We need sometimes multiple puncture to achieve a stone-free rate, and sometimes we have trouble. So we have some fragments which we migrate in some inaccessible calyx with rigid instrument like standard PCNL, and so that we will have residual fragments. For IRS, the stone-free rate is lower than PCNL. Usually, we need multiple sessions to achieve stone-free rate, especially with a high stone burden. We are working with a high pressure even if we are using an access sheet, and this will expose us to the risk of urosepsis. What's the ICRS? Endoscopic combined internal surgery, but what is it? It's simultaneous smart use of two complementary techniques, which are the percutaneous nephrolitotomy and retrograde ureteroscopy. Why? To overcome limitation of monotherapy approach and to achieve a higher stone-free rate in complex stone in a single session. It's very important to set up the operating room so to have a comfortable condition to both operators. We are using two teams of urologists, two teams of nurse, two monitor and two energy for fragmentation. First, we will use the retrograde internal surgery just to have a look to explore the whole upper tract, and this will allow us always to have an endoscopic view so that will help us to the next step, which will be the percutaneous treatment. We started with the puncture. So with the endoscopic view, we will have a safe and a secure function so that we will avoid some trouble. And as we see in this slide, this puncture, which is very acute and it sees just where we need. Then the endoscopic view will allow us to have a control of the dilation so that we will have a safe dilation without injury to the upper tract, and we will have a control of our dilator even if we are used the Teflon one or the Alken. The fragmentation will be the same. So we are using usually the ultrasound and ballistic source for standard PCNL. For mini PCNL we are using the laser energy. For ureteroscopy we are using laser energy with 270 micron fiber laser. And for the advantages of this technique, that we are not obliged to have a diastase, so we can just fragment some big fragments, and because we are using the PCNL in the same time, we can use the pacing ball technique. What is it? It's just like we are seeing here. So the flexibility will go and look for fragments which are inaccessible with the PCNL, with the microscope, and it will bring it, expose it to the grasper from the PCNL, and so that will be kept out by the implant sheet, and we will have a gain in matter of operating time and in matter of whole overall operating time, and we can take off big fragments, so we are not obliged to have a dosing and having a longer time. For whom? This example of a huge renal stone with a stone taking the whole ureter till, as we see here, till the bladder. So we used in 2 sessions, because we used first time the ureteroscope, then the flexible ureteroscope to complete the fragmentation of the whole ureteral stones. Then we are using the persistence nucleation. And for this stone on this KUB, we can see that it's complex staghorn category with multiple calyx. So to achieve stone free rate for this stone, we are having to have a lot of puncture. But if we are using ICRS, it will be easier. So we can start and fragment this part, and we can use the PCNL for the rest of the stone. So we will have a gain in matter of stone free rate and in gain in matter of operating time and number of sessions. So the advantages of this ICRA is to achieve a higher stone free rate in complex stone in single session. According to this paper from Mr. Scofoni, the ICRS in matter of urology will allow us to avoid multiple puncture, to improve stone clearance even when we're using the technique of washout. It means that we will use the pressure and the irrigation from the flexible ureteroscopy to wash out the small fragments from every calyx, because it's flexible. It allows us to explore the whole upper urinary tract. To reduce intrarenal pressure, because we have an implant sheet and we have a flow going out through the access sheet. Then we have a less nephron loss because we are using a single puncture, a one tract. Then the possibility of treating the other side, and also reduce X-ray exposure because we are using the view of the endoscopy to occur the puncture and to guide the dilation. When we are thinking about our friends, the anesthesiologists, yes, they are more comfortable with this fine position because there is a better airway control, there is less risk of injury to nervous system, there will be a shorter operating time, and that will reduce the risk of thrombosis, and it allows us to make it under local anesthesia. According to this paper from Mr. Scofoni, there is a gain of operating time in favor of ICRS, and we have more than 80% of stone free rate in single session with ICRS. Then the hospital say it's less with ICRS, we have a gain significantly. Then for the complication we have also 5 to 44%, but almost Clavian grade 1. So not very dangerous complication. Limitation of ICRS is the need of 2 teams of angiologists and nurses, 2 on the vision systems and 2 fragmentation devices. A lot of armatorium. In conclusion, we can say that the current stone treatment armatorium allows to handle many difficult cases. Patients with complex, high-burden stone might benefit from the endoscopic combined internal surgery. This must lead the urgent to the personalized stone approach, PSA, which imposes to set up an experienced teamwork to face such challenging cases. Team means together everyone achieves more. And thank you for your attention.
Hello everybody, I am Dr. Ahmed Sadi. I am urologist in the urology department of Charles Nicolle Hospital in Tunisia. I'm glad to be part of you today in the AUA Congress to present this lecture about the management of the complex renal stones. So we will start with our case presentation. It is about a 53 years old woman complaining about a chronic right back pain. She had a body mass index of 35 and a normal serum creatinine level. Her urine culture was positive and a portiosus mirabilis was isolated. In abdominal plane X-ray, we may notice a complete and complex staghorn stone on the right kidney. An intravenous urography showed a normal nephrogram in both sides and confirmed the diagnosis of complete staghorn stones of the right kidney without dilation of the collecting system. So we are facing a case of a complex staghorn stone, which is in this context an infection stone. In these cases, the main objective is to anteriorly remove this lithiasis in order to avoid recurrences. So, what would be the best surgical technique to have a stone free? We discussed this case in our staff and we decided to perform an anatrophic nephrolitotomy. There are two concerns that arise concerning this technique: its efficacy and its safety. First of all, the anatrophic nephrolitotomy technique is based on the kidney vascular anatomy. In fact, the renal arteries divide before entering the renal ileum into anterior and posterior divisions. The anterior division further divides into the upper, middle, lower, and apical segmental arteries, while the posterior division forms the posterior segmental artery. The renal artery vascularization is of terminal type, and there is no anastomosis between posterior and anterior arteries. The parenchymal incision is made in the avascular intersegmental plane between posterior and anterior segments on the convex border of the kidney along removal of large renal calculi. Our patient was operated by a lumbotomy incision. The renal pedicle was carefully dissected. Then, methylene blue was injected in the posterior renal artery. The posterior segment of the kidney was colored in blue and we obtained a line of demarcation corresponding to the intersegmental plane in which the parenchymal incision should be performed. After a selective clamping of the renal artery, a nephrolitotomy in this plane was performed. All peeling and calicial stones were removed. Then, nephrography in two planes was performed. The warm ischemia time was 15 minutes. The total bleeding was 200 milliliters and the duration of the procedure was 18 minutes. The operating follow-ups were simple. The drain was removed 2 days postoperatively. The patient was discharged from the hospital at the 4th day and the postoperative abdominal X-ray of the patient was stone-free. The stone did not recur after 6 years of follow-up with a negative urine culture. So we can say that this technique is effective to treat a complex staghorn stones. In fact, many studies showed that stone-free rate in case of complex staghorn stones of the kidney range from 49 to 90% when treated by PCLL, while the stone-free rate exceeds 18% and may reach 100% when treated by Anatrophic Nephrolitotomy. Now, it is a safe procedure. 3 months postoperatively, our patient who had a DMSA scintigraphy which showed relative right renal function at 38% versus 44% preoperatively. In a review of renal recovery after anatrophic nephrolitotomy published in the World Journal of Nephrology in 2015, 3 studies showed an improvement or stabilization of renal function after anatrophic nephrolitotomy in 100%, 62%, and 87% of patients respectively, while 2 other studies showed degrees of renal function of 81% and 100% of patients respectively, but the percent of reduction was 4% and 9%. So to conclude, this anatrophic nephrolitotomy seems to be an effective and sure procedure in treating patients with large volume and complex tag hole calculi. It can be then proposed for such type of stones, provided that it is conducted by surgeons used to perform it. And thank you for your attention.
Dear Chairman and colleagues, allow me to present to you today this prostate cancer case report. I am Mohammed Marabti from the Department of Urology of Mohammed V Military Hospital in Rabat, Morocco. First, I have no potential conflict of interest to report. Our patient is 70 years old with no past medical history and good general health status. ASA1, PS0, Karnofsky 100%. In 2019, he presented at his first urological consultation. He was suffering from lower urinary tract symptom with an international prostate symptom score of 12. He had no erectile dysfunction, the international index of erectile dysfunction domain score of 23. His first prostate-specific antigen level was 18 nanogram per ml. At digital rectal examination, no nodule was palpable. The patient underwent multiparametric MRI of the prostate, which was positive for a 10 mm lesion in the right lobe. No capsular or seminal vesicle involvement was shown. The patient underwent transrectal prostate biopsy. Out of 12 random course, 3 were positive for adenocarcinoma of the prostate, ISUP group grade 1. The staging was completed with a CT scan and bone scan. The bone scan confirmed the presence of unique suspicious metastatic lesion in the right ischium. This lesion was confirmed on the fluorocholine PET scan without further metastatic lesion. In summary, the patient was newly diagnosed with a CT1C N0 M1B ISUP group grade 1, low volume according to charted criteria and low risk according to latitude criteria metastatic prostate cancer. So, what is the evidence of treating primary tumor in de novo oligometastatic disease? The primary tumor, which we can see over here, is all-time sharing out exosomes but also cytokine to the bloodstream. And these exosomes and cytokine exit the bloodstream and they go to other organs like bone and lung. But to become metastatic and to grow, these cells need create a choke with primary tumor. So the rationale of treating the primary tumor is to stop this continued crosstalk between metastatic spot and primary tumor. The second strong point is the persistence of little cancer in the primary tumor after systemic therapy, which can contribute to progression. that was shown in this prospective study, which included patients with prostate cancer who underwent 1 year of ADT and docetaxel treatment followed by prostatectomy. Immunohistochemical analysis of specimens showed that molecular features associated with potentially lethal prostate cancer remain in tumor cells within the primary site after aggressive treatment despite favorable therapeutic response. The Stampede trial has put in page 2 a very catchy saying: proliferation of tumor cells at distant sites to form over metastasis is dependent on compound, not cell, but compounds secreted by the primary tumor into the circulation. Now we go back in time, 7 years prior. European Urology published the possible benefit of surgery in case of metastatic prostate cancer. Data from the Munich Cancer Register between 1998 and 2010 showed that patients who underwent radical prostatectomy have a 55% 5-year overall survival rate compared with 21% in patients who underwent radiation or just EDT treatment. Also, Samuel Antwi in this retrospective study showed that definitive local therapy of the primary tumor may improve survival in men with metastatic prostate cancer at the time of diagnosis. Nicola Fossati and Leppenberg in 2 previous studies showed also a potential and beneficial impact of local treatment of the primary tumor in patients with metastatic prostate cancer. In 2016, Journal of Clinical Oncology published a study that showed that adding radical prostatectomy to ADT is better than ADT alone. And the very important point is that giving a low dose of radiotherapy, less than 65 gray, is the same as doing nothing. So the take-home message is, if you choose go for radiotherapy in primary tumor in the de novo oligometastatic prostate cancer, go for high dose, not for palliative low dose. In this paper of Parikh in the Prostate Journal, which is analysis of national cancer database in the United States, the results are quite important. No local therapy showed poor overall survival in patients with metastatic prostate cancer. The same thing was shown with low dose of radiotherapy. But radical prostatectomy and modulated radiation therapy was associated with improvement in overall survival for these patients. Of course that all these studies are retrospective data, but in this recent and first case control study, Heidenreich included 61 patients, all have less than 3 bones metastasis and no visceral or lymph node secondary location. All patients underwent flare-up prophylaxis followed by ADT with LH-RH analog for at least 6 months. Those with PSA decreased to less than 1 nanogram per ml were candidates for cytoreductive radical prostatectomy. The cancer-specific mortality and overall survival were better in the radical prostatectomy group, and time to develop castration-resistant prostate cancer was 40 months versus 29 months in group without local therapy. Nowadays, 2 prospective studies have recommended radiotherapy for local treatment in patients with oligometastatic prostate cancer. If it is possible with radiotherapy, why not with surgery? Maybe because of morbidity associated with this surgery? Félix Pressé, in his retrospective study, showed intra- and post-operative complications associated with cytoreductive radical prostatectomy are higher than those in non-metastatic radical prostatectomy. But these complications rates appear manageable. Heidenreich also, in his study, showed that cytoreductive radical prostatectomy is a safety procedure with a better oncological outcome. After discussion with multidisciplinary team, the patient opted for a multimodality treatment consisting of combination of ADT, surgery and radiation therapy. The histopathological examination of the prostatectomy specimen show a PT3B, PN0, R0 prostate cancer, ESUP group grade 3. 1 month after surgery, the first PSA level was 0.25. Urinary continence was good, but erectile dysfunction was reported. Stereotactic radiotherapy was initiated 2 months after surgery, and PSA control was indetectable. 1 year after radical prostatectomy and metastasis target therapy, PSA was rising slowly. We realized a pelvic MRI and colon PET scan, which suspect a pelvic recurrence without further location, and patients benefited from pelvic radiotherapy with good response up to date. To conclude, oligometastatic prostate cancer is more and more frequent and is considered as a real therapeutic challenge. This clinical situation demands personalized and individualized surgery. Currently, the previewed benchmark articles are still poor and of low level of proof, all while awaiting the results of these current studies. Thank you.
Good morning, everybody. It's with great pleasure we speak today about the locally advanced prostate cancer. First, prostate cancer in North Africa is not the same compared with the other countries like America or Europe, with an impact for 13.2 per 100,000 persons and a rate of mortality about 5.4. Prostate cancer occupies the third place for cancer in men in Algeria, second urological cancer after that of the bladder. Estimated number of new cases of prostate cancer in 2015, 1,620, for projection 2024, 4,000 cases. Standardized incidence rates 11.8 per 100,000 men. Mean age of diagnosis 71 years, median age at date 8 years. This progression is likely to worsen further as happening in developed countries. For example, in Algeria, it's the same thing as North Africa, with 10 to 24 cancer per 100,000 men. Mortality is inferior as 5. So, increased incidence since 2000. The current incidence is still very well in developed countries. The locally advanced and metastatic stages remain by far the most frequent stages in Algeria. Lack of exact global or specific mortality figures for prostate. So, we try to speak how to manage locally advanced prostate cancer, especially the unplaced like this first case, where the patient was 66 years, PSA was 8, digital rectal examination T2A, MRI 1 left lesion pyrus 5, no extracapsular extension, no left nodes. Have 4 positive biopsy, the USP was 3, and the bone scan was negative. So, prostate localized intermediate risk prostate cancer, and uropathology was PT2C USP R0 pat with 1 lymph node per 14. The PSA after 8 weeks was 0.06. In practice, almost half of our radical prostatectomy were high risk with 4% PN1. So, in this situation, what is your operative strategy? It's the same situation, of course, Briganti defining the cutoff for 2 lymph nodes. So, this sure patient with, for example, 5 nodes length, it's more poor prognosis. This early study of messing with a few patients to compare adjuvant hormonotherapy versus monitoring who hormonotherapy improves overall survival. In the opposite, SIN database demonstrated no difference between the two options. There is to the question about radiotherapy. We have an Italian study in favor of to combine radiotherapy and hormonotherapy improves overall survival. The study was completed with the other trial with 1,000 patients, and we see a clear profit to associate the radiotherapy to hormonotherapy. But maybe not for all the patients, maybe for T3, T4 with 2 to 3 lymph nodes. So, at the guidelines, we stay for the strategy with adjuvant hormonotherapy combined with radiotherapy or simple monitoring, and depends the number of lymph nodes and postoperative PSA. Okay, for the second case was a man with 67 years, PSA was 14, right T2A, MRI, E T2 with 1 iliac lymph nodes, have 6 positive biopsy, and the CT chest, upper abdomen, and bone scan were negatives. So we have prostate cancer locally advanced high risk CT2 and 1M0. Is a few years old, this patient was treated by only hormonotherapy like metastatic cancer, but now is there place for local therapy for this patient? First, for surgery, maybe yes, like the study of Mayo Clinic with the best survivor. This German study was demonstrated the patient with local therapy and better, of course. There is too, this American database has proved the benefits of the overall survival than the only hormonotherapy. Which prostatectomy? The radical prostatectomy. In this situation, like this old slide, we speak about extended prostatectomy without nerve sparing, but we can use MRI as a decision tool to select patient for sparing or no, and from that we speak about custom surgery, but we must be on R0. Now for adenectomy. Why to perform lymph nodes dissection? No means of exploration by imaging has the specialty of urology. Majority of nomogram remain imprecise. Lymphadenectomy is one of the tools of the work. Of course, it indicates adjuvant therapy and maybe curative value in case of micrometastasis. So the lymph nodes dissection is imperative with a good quality. We must ride up to crossing ureter to take off the iliac part and mostly under the obturator nerve. In any case, it does not make sense to practice surgery with lymphadenectomy. It's a little complicated to speak about therapeutic effect, but the lymph node dissection gives better certification for discuss adjuvant therapy. Also, the question that arises, it's necessary to look for the nodes at spontaneous exam. The answer is no. If we start with surgery, the lymphadenectomy must be extended. The radiotherapy improves too the overall survival in this patient. The stamped study where we have a real benefits for the EBRT. In surgery option, do we need to complete the staging? Maybe no. We have metabolic imaging. We have one lymph node clearly visible and very suspicious in MRI, and maybe yes, if availability, more difficult situation, change the therapeutic strategy. And if you chose the radiotherapy, do we need to complete the staging? You have PET scoring, PSMA, yes, for to confirm malignant nodes, other nodes, and get the boosts. In Algeria, we have only 2 centers of PET scan. The first one was in private hospital since 5 years, and the second in public hospital. Guidelines: there is not place yet for metastatic imaging in locally advancing cancer. We don't know if the PET scan will change the oncologic outcomes and improve prognosis. Finally, surgery is a good option to discuss with the patient, good outcome in select patients, and possibilities of adjuvant therapy in multimodality approach. The patient has a radical prostatectomy with lymph nodes dissection. The uropathology was PTGA used for R0, 1 lymph nodes with extranodal extension, and the PSA after 8 weeks was 0.16. The decision was adjuvant hormone therapy with, of course, radiotherapy. And thank you for your attention.
In this case, we will discuss the pathways to the diagnosis of prostate cancer in a patient followed during 10 years. I have nothing to disclose. A 54 years old patient with no family history of prostate cancer, a PSA in 2011 6.9. He was asymptomatic, and rectal examination showed the 40 grams prostate with normal consistency. Transrectal ultrasound guided biopsy showed no cancer. During follow-up, the PSA was oscillating between 6 and 7, and in 2014 it increased to 7.5. A multiparametric MRI showed an 8 millimeters lesion and the transitional zone, hypointensine T2 and hyperintensine diffusion weighted imaging. A combined systematic and targeted biopsy showed no cancer. After 2 years, the patient presents lower urinary tract symptoms. He was given tamsulosin, and in 2018, the PSA increased to 9.9 with a density 0.16. A multiparametric MRI showed the Pyrus 4 lesion and the peripheral zone. A combined systematic and targeted biopsy with a cognitive fusion showed no cancer, only benign prostate hyperplasia. After 1 year, the PSA increased to 11, and the multiparametric MRI showed no lesion with a prostate volume of 75 grams. So the Pyrus 4 lesion disappeared on repeat MRI after 1 year. In 2020, the PSA was stable, but the patient worsened his lower urinary tract symptoms. Our decision is made based on clinical parameters and MRI, and we don't use biomarkers so far. The PSA density 0.15, the Epfront MRI was normal, normal consistency prostate with enlarged 75 milliliters, in a patient is 63-year-old with multiple prior negative biopsies. If you use the Rotterdam prostate cancer risk calculator, the patient has only 1% risk of significant prostate cancer, and if we combine the MRI that was normal, also he has 1% risk of significant prostate cancer. If the Pyrus was persisted, the risk of significant cancer would be 12. The patient worsened his lower urinary tract symptoms, and we decided endoscopic bipolar enucleation. It was difficult with a postoperative sepsis, and histopathology showed no cancer. 3 months after enucleation, the PSA dropped to 1.2. This study assessed the role of PSA monitoring after hormone laser enucleation of prostate. After enucleation, if the PSA is more than 1 and the density is more than 0.1, these patients are at risk of harboring significant prostate cancer, should be biopsied, and here clinicians should be aware and the shift of PSA after enucleation. Multiparametric MRI is an upfront in a diagnosis of prostate cancer. It was highly recommended in prior negative biopsy, now is being recommended in biopsy naive patients. Two strategies: to rule in significant prostate cancer or to rule out clinically significant prostate cancer and use the MRI as triage test. The PROMISE trial and the Precision two landmark prospective studies that assess the role of MRI and the diagnosis of prostate cancer. For Precision trial, the MRI pathway with targeted biopsy detects more significant prostate cancer and less insignificant prostate cancer as compared to systematic biopsy. The PROMISE trial shows that MRI has a high negative predictive value, and if it is normal, only 1 in 4 may have Gleason pattern 4. So from these two studies, the suggestion was MRI for all, targeted for many, and systematic biopsy for those with high risk. So we have new tools. You have risk stratification tools in addition to MRI to improve the detection, the decision making. And the literature, there is an added value of combining biopsies. The target biopsy and systematic biopsy combined provides the greatest detection of significant prostate cancer. And the added value of MRI target biopsy is higher in prior negative biopsy than in biopsy naive patients. That's why the European guidelines strongly recommend to combine targeted and systematic biopsy in biopsy naive patients and recommend only target biopsy in prior negative biopsy patients, but the strength of rating is weak. Can systematic biopsy be omitted? This study shows we can omit systematic biopsy in men with PIRADS 5 and PSA density greater than 15%. If the PSA density is superior to 0.15 nanogram per square milliliter, if standard biopsy is omitted, only 4% of significant prostate cancer are missed. The limitation of MRI is the high rate of false positive, as it is shown in PROMISE trial. In PROMISE trial, the rate of false positive is more than 40%. When we have a PIRADS 4 or 5 lesion and the biopsy is negative, what next? This study shows that false positive MRI lesions are distinct from significant cancer-associated lesions in patients from PROMISE trial. And the lessons from PROMISE trial was these significant cancer-associated lesions, these true positive lesions are mostly multifocal, with larger index lesions, are more conspicuous and more visible in all sequences with a more diffusion restricted and higher PSA density. So for indeterminate MRI phenotype, PSA density and EDC could predict significant prostate cancer. PIRADS 4 or 5 also can be benign lesions, and this study shows the follow-up of men with PIRADS 4 or 5 abnormality on prostate MRI and non-malignant pathological findings on initial target biopsy. 18% of patients with PIRADS 4 or 5 abnormality have no cancer on target biopsy. And PIRADS downgraded and repeat MRI in 73% of cases. So the persistence of PIRADS 4 or 5 predicts a high risk of missed cancer. This raises a worthy question. Is Epfront MRI always necessary? This study shows that we can reduce unnecessary prostate MRI by using clinical parameters to predict negative and indeterminate findings. When the PSA density cutoff is 0.078, the negative predictive value is very high. So this leads to 29% fewer MRI to be performed and only 2 clinically significant prostate cancer to be missed. So MRI has limitations. There are many cases of false positive and false negative, and also interleader variability. So we have, in addition to MRI, to find new tools. These tools are risk calculators, biomarkers, and new models. Only 2 of them are FDA approved. And the PSA density with a cutoff of 0.15 is a valuable clinical parameter, cost-effective, that improve the decision-making and selection patients for biopsy. The European guidelines recommend risk calculators and imaging and recommend biomarkers, but the strength of rating is weak, while NCCN guidelines recommend to consider biomarkers. This is an excellent review of risk stratification tools in prostate cancer diagnosis, combining biomarkers, risk calculators, and imaging, and shows the role of prediction medicine and the decision making. The tools are either risk calculators including standard parameters or risk calculators including biomarkers next to clinical parameters. The MRI is considered as clinical biomarker, and the risk calculators including MRI data and the combination of novel biomarkers and MRI. So there are many strategies, combined strategies to diagnose this pathway, combine risk stratification tools. Either upfront risk calculator with standard parameters and if indicated subsequent MRI and biopsy, or upfront risk calculator with standard parameters and novel biomarkers and if indicated MRI, or upfront novel biomarkers and if indicated subsequent MRI. Different scenarios combining biomarkers and MRI. And this study shows the different possibilities, different options, either upfront biomarkers or upfront MRI. So many options, and they think the choice depends on what is affordable, what is available, and what is easy to perform. Thank you.
Before closing this Maghreb session at the AUA Las Vegas 2021 Congress, I thank the various speakers and moderators. I thank the American Association of Urology and its staff. I thank Dr. Henry, President of Algerian Urological Association, and Dr. El Kamel, President of Tunisian Urological Association. I would say that the various themes chosen were relevant and reflect a urological reality of the Maghreb, which is on the right way. Finally, hoping to relive the Maghreb session in New Orleans 2022.